Namaste from India. I'm Dr. Nidhi Puri, Professor in Anatomy at All India Institute of Medical Sciences, Bilaspur. This is the beautiful campus of All India Institute of Medical Sciences at Bilaspur. It is located in Himalayan state, Himachal Pradesh of India. The topic of my today's discussion is about the 3D anatomy of bronchopulmonary segments for VATS. As we know, the lung conservation surgeries are the preferred surgeries these days for better function of the lung post-operatively. The anatomical segmentectomy is gathering increasing interest among the thoracic surgeons. And for minimal invasive surgeries, bronchopulmonary segments are also increasing the interest to the surgeons. So in this slide, we will just go through hurriedly about the anatomy of bronchopulmonary segments. As we all know, both the lungs are divided into the lobes. The right lung has 3 lobes, upper, middle, and the lower lobe, and while the left lung has only 2 lobes. So if you look at each lobe on the right side, first of all, the upper lobe has 3 segments, that is apical, posterior, and anterior. While the middle lobe has 2 segments, medial and lateral, and the inferior lobe has 5 segments, that is superior, and then 4 basal segments, that is anterior basal, lateral basal, posterior basal, and medial basal. Medial basal is also called as cardiac segment. While on the left side, in the upper lobe, we have 4 segments, while towards the apex, we have one segment called apico-posterior, where 2 segments are joined together to form one segment. And then we have one anterior segment. Then lingular area has superior and inferior segment. While the inferior lobe has 5 segments of same nomenclature, but here the cardiac segment or the 7th segment or the medial basal segment is either rudimentary or may be absent, and because of the high pressure of the left ventricle. So these segments have been numbered from 1 to 10 from apex to base on both the sides. But in the left lung, since there are 2 areas where 2 segments have merged together or may be absent, so that is why we say that left lung has 8 to 10 segments. Then each bronchopulmonary segment, which is a structural as well as functional unit of each lung, it is pyramidal in shape with an apex directed towards the hilum and the base towards the periphery. It contains artery, vein, and the bronchus. Bronchus here is the tertiary bronchus, which is aerating the bronchopulmonary segment, while segmental artery is derived from the pulmonary artery. These 2 structures are lying buried in the parenchyma, while the vein, it runs in the connective tissue which is dividing the 2 segments, and so the vein is intersegmental here and it is draining adjacent segments. This is a fiber model of the lung where I have placed them in particular views so that we can have an idea which segments are better viewed from which particular view. So this is the anterior lateral view for both the lungs. We can see that here on both the sides, 3rd, 4th, 5th, and the 8th segments are better seen from anterior aspect, while superior or the 6th and the 9th, both of the inferior lobe are better seen from the lateral side. In the posterior view, we can visualize very nicely the 3rd, 6th, and the 10th segments. But since posterior approach is not done to approach the segments, it is only through the anterolateral aspect. So if these segments are to be approached anterolaterally, the surgeon has to maneuver towards the posterior. This is the medial view. On the right side, the medial view is giving a very good view of the 7th segment or the cardiac segment, which is seen only on the right side, and which is, as I said, that it is rudimentary or maybe absent on the left side. So if we have to approach the 7th segment, then it lies very close to the hilum. So from the anterolateral aspect, it is better approached through the oblique fissure. CT scan is the gold standard of investigation for identifying the bronchopulmonary segments. And we can see in these sections, when we move from apex to the base of the lung, we can visualize almost all the segments. And if we do digital reconstruction of these slices, we can have a nice view of the segments, all the segments mapped in the complete lung. Gao and Liu, they have reported demarcation of the segmentations in the CT images by seeing the gaps in the images of the parenchymal tissue. So this can be helpful in demarcating the segments to identify the area or the area of lesion or to a segment of approach. As we can see that each segment has a tertiary bronchus, segmental artery, and is surrounded by intersegmental veins. These three structures can be the guiding force to decide about the resection margins of each segment. In areas or in the segments where the bronchus and the arteries are easily approachable, so these two are considered to be the guiding, you can say, guiding structures for the dissection of the or the resection of the segment. But in case of segmental arteries and the bronchus are deep located in the lung parenchyma, to reach this target bronchus, we can dissect the parenchyma along the intersegmental veins, and this will help guiding us to reach up to the bronchus. So this method can be used for those segments which are more laterally or more posteriorly placed, like segment 9 and 10. We can identify or we can locate the segments preoperatively as well as intraoperatively to decide the area which has to be resected. So there are various methods which help us to decide about the segment markings. So there are certain preoperative and methods. Among them, most popular one is the CT scan, where through MDCT we can again reconstruct the images and from the slices, and we can decide which should be the approach to reach particular segment. Then another method is by using 3D printing of the images of the CT. And this 3D printing is actually very popular with the anatomy departments. So which is used for developing models to teach the students, but this can also be used by the surgeons preoperatively to decide about the area of approach or area which they have to resect. While intraoperatively, to identify the segments, there are various methods which have been popular now. One most popular is the inflation and deflation techniques. In this, we need an extra manpower who will be handling the bronchoscope to either inflate or deflate the particular segment by putting the bronchoscope into the concerned tertiary bronchus. So, but the limitation here can be air embolism. Then this inflation and deflation technique can be further made better by using hook wire, which can be put through the margins so that we can decide about the resection margins. This is done under the CT guidance and is helpful in deciding about the resection margins. But in case if there is a threat for the air embolism, then in that case, we can use indocyanine green injections, which can be put either through the bronchus or through the veins. Then in that case, in case of if we are using it through the bronchus, then emphysematous lung can be misleading because the dye may reach the area more which is beyond the segment limitations. But if we are using intravenously, then the dye may use through the collateral circulations may again reach the areas which is beyond the segment and may mislead the surgeon. But otherwise, it is a very frequently used method. This will stain the parenchyma and demarcate the concerned area. Then another method, which is a latest method and is being popular nowadays, that is virtual assisted lung mapping or VALMAP. In VALMAP, we use virtual bronchoscopy, and through the virtual bronchoscopy, we put the dye, that is again ICG or methylene blue dye, which can be which can help in staining the parenchyma of the segment, and that will guide the surgeon on the table. This can design the resection lines even beyond the conventional anatomical segments. But the limitation here is that we need more preparation. And another is that it can mark only the peripheral aspects. But if we need to do some dissection in the deeper parenchyma, then it does not stain the deeper parenchyma, and it may become difficult for the surgeon. Therefore, we conclude that 3D anatomy of the lung segment is important in VATS for not only locating and the disease or the lesion, but also for deciding the resection margins, localization of the target segment, and approach to the target segment. Thank you.